I'm Dr. Charles Shepherd. I'm a UK physician with a long-standing clinical and research interest in ME/CFS. I'm medical advisor to the UK ME Association, a patient support charity, provides information support to people with ME and to health professionals. I was a member of the committee that produced a new NICE guideline on the diagnosis and management of ME/CFS here in the UK. And I got interested in the overlap between ME/CFS and long COVID round about sort of May 2020, when the pandemic had been going for several months. And we were starting to see an increasing number of people who clearly had an ME/CFS component or even a diagnosis of ME/CFS following COVID. So we've got an awful lot of people with ME/CFS and long COVID now. It is a major public health, I think, crisis. The figures are not precise, but I mean, there's been estimates that worldwide we could have about 60 million people with ME/CFS and possibly even 400 million people with some form of long COVID. Just quickly before I go into what is basically what I think are the five key basics of management of these conditions, just a little bit on the overlap between the two conditions, because we're going to talk about the management of key symptoms of both conditions. So ME/CFS has a number of key diagnostic symptoms, and many of these symptoms, in fact, sometimes all of these symptoms are present in most, not all people with long COVID, but most people with long COVID. So we have this group of this cluster of symptoms, which are primarily activity-induced, really debilitating fatigue, cognitive dysfunction, which is also known as brain fog, unrefreshing sleep, so people don't feel any better when they've had a good night's sleep, various symptoms connected with autonomic nervous system dysfunction, dysautonomia, so we have orthostatic intolerance, this inability to remain upright and do things in a standing position, POTS, postural orthostatic tachycardia syndrome, pain, which can be arthritic, myalgic, or neuropathic. And one symptom in particular, which is very relevant to management, something called post-exertional malaise or symptom exacerbation. And this is where these patients will push, well, not necessarily push, but they will go towards the limit of what they can do cognitively or physically during the day. And if they do that, and certainly if they push beyond what their limitations, then they get this curious delayed exacerbation of symptoms, which quite often comes on 24 to 48 hours later and can take a long time to fully get back to normal if they push themselves into one of these post-exertional crashes. So that's very important in relation to how we manage these conditions. I'm just going to try and cover a lot of ground and really do the basics. And I think there are five basics to the management of these conditions where they overlap. And as I say, not everyone with long COVID has an ME/CFS component or meets diagnostic criteria for ME/CFS. There are certainly people with long COVID whose primary problem are related to cardiac, respiratory, long-term effects from the virus, loss of taste, loss of smell, these other things. And I'm not going to go into that because that's not my expertise, it's not my area of interest. And that's really, I think, a totally different subject. So it's where long COVID and ME/CFS overlap. And the first key aspect of management is to make sure the diagnosis is correct. And I think it's important to try and get an early diagnosis. 3 months of symptoms is the diagnostic criteria for long COVID, failure to recover within 3 months of the onset of COVID. And here in the UK, although I know this is not the situation in many other countries, here in the UK, the NICE guideline recommends that we should be aiming to make a diagnosis of ME/CFS at 3 months from the onset of symptoms. And this is terribly important because it's not only making a diagnosis and managing these people at 3 months, but actually suspecting this diagnosis in that period up to 3 months. They've had an infection, they're not recovering from it, they've got ME/CFS-like symptoms, and you should be plunging in with sensible advice on management, even though you don't feel you can make a firm diagnosis at that point. The second point on making this diagnosis is that a lot of consultations are now on the internet, and really this is a diagnosis that must be made in a face-to-face consultation. In other words, a good clinical history, an examination of the patient to make sure there's nothing else suggesting that there's another cause, and then arranging a range of tests. And really, I don't think you can do this in less than half an hour. Ideally, you need half an hour to an hour with these patients, because they do have quite complex histories, and there's a lot of stuff that you want to try and compress into the management as time goes on. And I think there are three other reasons why you want to make this early and an accurate diagnosis. First of all, there's a lot of misdiagnosis. It's been going on for years in relation to ME/CFS. It's very easy to plunge this diagnosis into someone who's just tired all the time. You can't find an explanation. And it turns out when it's properly investigated, they've got something like sleep apnea, myasthenia gravis, celiac disease, Addison's, there's a long list of things. And more seriously, although those are serious conditions, we know that people get misdiagnosed as having cancer when they've actually got cancer. And that's a real tragedy. And if you follow the press reports, as I have to do, you will see that this is happening with long COVID as well. People are not being properly assessed. They're being given a diagnosis of long COVID because they haven't recovered from COVID and they're breathless or whatever. And in actual fact, they turn out they have a malignancy. Secondly, certainly in relation to long COVID, this is an infection which seems to be triggering the onset of other diseases which have been laying there dormant, subclinical for until the COVID comes along. So there are people developing things like diabetes, ischemic heart disease. So that may be, part of the clinical picture, may even be an explanation as to why they're not recovering from their COVID. And thirdly, there are a number of comorbidities which are quite common with these conditions, particularly things like irritable bowel syndrome, mast cell activation syndrome, and you've got something in a woman who's in later life and possibly going through the menopause. That can complicate the clinical picture. So you've got a complicated clinical picture in many of these patients to deal with. Just a quick note on the investigations. All of these patients, I think, should have the routine investigations that we do for ME/CFS. So that's inflammatory markers, ESR, CRP, full blood count, ferritin, U's&E's, liver, thyroid, renal tests, HB1AC for diabetes, celiac screen, vitamin B12, etc. So I think those all should be routine. And then depending on what else is going on, what other symptoms they've got, you may want to do some other tests. You may want to do, this can be done in the surgery quite easily, a NASA lean-to test if you've got someone suspected of having POTS. If you've got a more elderly patient, let's say someone in their 60s, you really need to make sure you're not dealing with something malignancy or a myeloma, so you might be checking calcium. If someone has got a lot of joint pains, then you may want to do an immunological screen, rheumatoid arthritis, lupus, whatever coming into the mix. If you've got someone with a low sodium turns up on the U's&E's, and they've got hypotension, low blood pressure as well, then you start to think about Addison's disease, can mimic this, certainly ME quite easily, and so you want to do an early morning cortisol. So, basic tests and then other tests on top of that. Second key point before we get on to actual, how practical management, talk to these patients, validate their experience, that they're often not believed, people don't know what's going on, and explain as far as you can what may be going on. This is an illness which is affecting all aspects of their life, their physical function, their mental function, family life, social life, their employment, their education. It's a very horrible thing to have, and they're looking for some degree of answers. So I think if you're going to be dealing with people with long COVID, you need to keep up to date to a certain extent with what's going on in research into causation and treatment, and just be able to give some sort of explanation as to why they are getting these symptoms. It may be that they've got an immune system which is in low level activation, which hasn't settled down, which some of the research is suggesting. And it may well be that they've got a problem with mitochondrial function where energy is being produced, and this may explain the fatigue, obviously. So, there's quite a lot you can do to help explain what's going on. You need to explain that we don't have a drug treatment, but there's no cure for these conditions. But having said that, there's quite a lot that doctors can do in relation to using pharmacological interventions to help some of the symptoms, and just giving the right advice on self-help management. And then finally, they want to know what's going to happen to them. So some idea as to what the outlook is, what the prognosis is. This is very difficult early on, obviously, to give this information. But as far as ME/CFS is concerned, this is very much going to be a long-term debilitating condition. The number of people who make a full sustained recovery is actually quite small. The prognosis that we're getting from 3-4-year-old follow-ups with people with long COVID indicates that certainly the prognosis is better. There's more people recovering from long COVID, but at the same time, there's plenty of people remaining ill for quite a long period with long COVID. Third key aspect then is actually dealing with symptoms. As I say, we've no cure, we've no treatment, although there's various clinical trials going on for treatments. And I think to start off with, certainly here in the UK, what we're trying to do is make sure that once the diagnosis is being made, that at least the patients have some start off by having a physician-led multidisciplinary team giving them advice. It may be involved a physiotherapist, an occupational therapist, dietitian, etc., giving them the advice which is going to turn them into expert patients, because if this is going to be a long-term condition, an awful lot of this is going to be self-help management. So it's guided self-help management, I think, is the crux of things at the moment. As I say, there are certain things from the point of view of prescribing drugs that doctors can do, particularly in relation to pain management, sleep disturbance management, and something like POTS. Different countries have different approaches to this pharmacological management. Here in the UK, for instance, with pain, we would have an analgesic ladder where you'd start at the bottom, simple over-the-counter painkillers like ibuprofen, paracetamol, even aspirin. I wouldn't really advise aspirin. These tend to be of very limited value in pain in these conditions. So you would then move up. Certainly here in the UK, we might consider using a low dose of a sedating tricyclic antidepressant like amitriptyline. You might move up the pain ladder and prescribe something like gabapentin or pregabalin. So there are a number of drugs which can be used. Equally, as I say, with POTS, there's quite a wide range of drugs acting in different ways, which can help with postural orthostatic tachycardia syndrome. But if as a physician, you are not used to dealing with POTS patients, you really need some advice from an autonomic specialist who's used to using these sort of drugs in a patient with POTS. The most important aspect, I think, of management of these conditions is fatigue. This awful problem with the debilitating fatigue that these patients have, and this activity and energy management, and adopting something called what we call pacing, whereby this is a very careful, gradual, individual way of managing your energy. So you're not doing too much, you're not doing too little, and you're splitting your physical and mental activities into little chunks of activity with rest periods, relaxation periods in between. If you're doing okay, then you gradually increase the amount of activity you're doing. If you're not, then you fall back. And that's terribly important in a condition which is fluctuating all the time. It's not something where you can just progressively increase what you do, which is why the NICE guideline no longer recommends what we call graded exercise therapy for people with ME/CFS. It just doesn't work. So pacing, there's lots of very practical advice that you need to be giving to your patients in regard to pacing. If you don't know about pacing, then you need to go and read it up. And there's plenty of good sources of information that you can give to patients or advise patients on pacing. Pacing also involves planning their activities and prioritizing their activities. And I think a good analogy to explain what's going wrong, why they feel so fatigued and debilitating, is that they've got a broken battery. Their battery is constantly flat, and the fact that they go to sleep, if they go to sleep and they wake up unrefreshed, is that they are unable to charge this battery. And it may well be like any flat battery, that the problem lies in the actual mechanics of that battery, and that's why there's a certain amount of evidence indicating that part of the problem in ME/CFS, certainly the fatigue component, lies with cellular structures called the mitochondria, where energy is actually produced within the cell, and that's something else you can explain to patients. And then finally, on symptoms, of course, some people inevitably will have quite a lot of emotional mental health issues in a condition like this, which is just taking away so much of their normal life, and they may need support in that direction from a psychologist or even a psychiatrist if there is a depressive component there. Fourth aspect is just a separate box here, I think is worth remembering, that around about 25%, certainly of people with ME, are severely or very severely affected. This means they're housebound. At the very severe end of the spectrum, they're bedbound, they may be tube fed, they require 24-hour care from people. And they're not only severely affected, and sadly many of these are severely neglected as well, because they lose contact with the medical professional altogether. Home visits, obviously, for physicians are very difficult to come by, and even where you have a referral service, it's very difficult getting this service into people's homes. So they are severely neglected, both in community care and in hospital care. Here in the UK, the NICE guideline made particular attention to this, and we've got a special section in this guideline, care of severe, very severe patients. And we've just had a new e-learning module on the NHS website on the care and management of people with severe ME, which is well worth doing if you're a physician who want to learn more about that. Finally, is just providing information, support, and signposting to these patients, because they're no longer able to work, or most of them are no longer able to work, or having to reduce their hours. Their finances may well be in difficulty, so it's important where benefits are available. Certainly there are state benefits here for disability and being off work, to advise them and provide support for obtaining these benefits or insurance-based benefits, and providing information support in relation to employment. Here in the UK, ME/CFS and to a certain extent Long Covid are covered by something called the 2010 Equality Act, which means employers have to make modifications for people who are not able to fully return to normal duties and activities. And I know there's quite a lot of legal cases going on. I saw one in Bloomberg Law yesterday in relation to a case in the United States. So support, information in relation to work, and especially for people who feel that they're at a point where they are able to go back to work in some form, but not in full-time work. The same applies obviously to education. Depending on where you are in the world, there may well be specialist referral centres for people with both ME/CFS and Long Covid. Here in the UK, we have both, although it's very disappointing to find that the Long Covid clinical services here in the UK are now being closed due to lack of funding. And what is happening in many cases is that the Long Covid patients are being transferred to the ME/CFS referral services. And finally, I must just mention, as I'm medical advisor to the MEA Association, and this occurs around the world, is that there are a lot of very good charities providing information support to people with this illness, providing detailed information on symptom management, benefits, and everything else that goes with this illness. The MEA, we've got an enormous range of free literature which can be downloaded from our website. We have a telephone, email support service called ME Connect. We have a Facebook page. So point them in the direction of the charities who can provide, hopefully, a great deal of additional information to these patients. Thank you very much for asking me to talk about these two very important conditions.